Newborn presentation of critical congenital heart disease. Newborns with critical congenital heart disease, CHE, may present with symptoms of cyanosis, congestive heart failure, CHF, poor pedal pulses, or a failed newborn CHE pulse oximetry screen prior to discharge. CHE lesions that are dependent on a patent ductus arteriosus PDA to support flow either to the systemic circulation or to the pulmonary circulation will manifest with shock or Volume 38, No. 10 October 2017, cyanosis, respectively, when the PDA starts to close. CHE lesions that allow shunting of blood to the pulmonary circulation manifest with progressive symptoms of pulmonary overcirculation as the pulmonary vascular resistance decreases. It may be challenging to distinguish cardiac disease from pulmonary disease or sepsis in a newborn with cyanosis and or respiratory distress. Chest radiography and assessment of response to oxygen and or positive pressure ventilation is clinically indicated to help to elucidate the cause. Lack of response to 100% oxygen for at least 10 minutes. Hyperoxygenation indicates that the etiologic origin for the clinical picture is likely cardiac, and further cardiac workup is indicated. Hyperoxygenation will help infants with pulmonary parenchymal etiologic origins and those with pulmonary hypertension as causes of cyanosis. A cyanotic newborn who is otherwise well-appearing may also have a hemoglobinopathy, such as methemoglobinemia. However, chest radiography and echocardiography performed to rule out cyanotic CHE are indicated in a cyanotic infant who is not responsive to hyperoxygenation. Features of CHF in a newborn include tachypnea, increased work of breathing, tachycardia, and hepatomegaly. While tachypnea and increased work of breathing may also indicate pulmonary disease or an inborn error of metabolism, hepatomegaly at examination suggests cardiac involvement. It is useful to percuss the top of the liver, as well as palpate its edge to estimate the liver span. Normal newborn liver span is 4.5 to 5.0 cm. The chest radiograph showing cardiomegaly and pulmonary vascular congestion in an infant with respiratory distress and normal saturations in all four extremities is indicative of a left to right shunting process. These physical examination and chest radiographic findings in a newborn prompt a differential diagnosis of obligate shunts, such as arteriovenous malformations. In comparison, these examination and chest radiographic features in a 2 to 8 week old infant with decreased pulmonary resistance suggest a dependent shunt, such as a large ventricular septal defect VSD. And terminal pro B type natriuretic peptide may be considered to help distinguish between non-cardiac and cardiac causes of respiratory distress. 6 severe pulmonary hypertension may also cause hepatomegaly and right ventricle RV dysfunction. Hyperoxygenation will help reduce the pulmonary vascular receipts, and ameliorate the pulmonary hypertension. However, in these instances, it will worsen shunting and pulmonary overcirculation in left to right shunt lesions. Weaker femoral pulses in a child who has otherwise strong radial pulses is concerning for cortation or interruption of the aorta. Weak femoral pulses in the setting of lethargy and other signs of poor perfusion and normal saturations are concerning for critical obstructive lesions at the level of the aortic valve or the aortic arch that require rapid prostaglandin initiation. Sepsis and inborn errors of metabolism are other situations that must be evaluated and or empirically treated in a sick newborn who has poor systemic output. However, cardiac evaluation with an electrocardiogram EKG, chest radiograph, and echocardiogram must be simultaneously initiated. The pulse oximetry screen for critical CHE in newborns was approved as a part of the routine universal screening program in 2011 and has been adopted in 46 states and the District of Columbia. 578, the most common protocol used is shown in Fig. 1. Variations exist, described elsewhere. A. This screen is intended to target detection of types of critical CHE that will manifest in the newborn period and require early intervention, including cortation of the aorta COA, interrupted aortic arch IA, tetralogy of fallout, truncus arteriosus, tricuspid atresia, total anomalous pulmonary venous drainage, double outlet RV, Epstein anomaly, pulmonary atresia, transposition of the great arteries, hypoplastic left heart syndrome HLHS, and other single ventricle lesions. Failed newborn screen may also indicate other disease processes, such as pulmonary hypertension, primary pulmonary parenchymal or interstitial disease, or hemoglobinopathies. Regardless, a failed screening result is an indication for prompt evaluation, including chest radiography, and echocardiography supervised and evaluated by a pediatric cardiologist. If cardiac investigations or pediatric cardiologists are not easily available in such a situation, initiation of prostaglandin infusion with close monitoring of the airway due to risk of apnea with prostaglandin initiation and prompt transport to a higher level central. Recommended. Congenital heart disease. Atrial septal defects. Atrial septal defects ASDs comprise 7% to 10% of CHD. 1, 2, 3, 4 based on their embryological origin. They can be classified as secundum ASDs, the most common type, due to a deficiency in the central part of the septum primum that develops from the middle of the atrial cavity and grows inferiorly to meet the endocardial cushion. Primum ASDs due to deficient proliferation of the endocardial cushion. Sinus venosus ASDs defects near the superior vena cava and right upper pulmonary vein, truly a form of partial anomalous pulmonary venous drainage, and other rare. 472 Pediatrics and review downloaded from http://pets and review, publications, /by967986 on January 30, 2019. Child and well, infant nursery 24-48 age of age or shortly before discharge of 4 Harvard. 3, 90% in RH or F, 90%, 95% in RH and F4. 3% difference between RH and F, 295% in RH or F, and 53% difference between RH and F. Repeat screen. NIH. RH or F, 90%, 95% in RH and F4. 3% difference between RH and F, 95% in RH or F, and $3% difference between RH and F. Repeat screen. And 1H. 90% in RH or F, 90%, 95% in RH and 4. 3% difference between RH and F, 95% in RH or F, and 33% difference between RH and F. Positive screen, negative screen. Figure 1. Flow. Clinical manifestations and diagnosis. ASDs are typically discovered when a murmur is heard at a regular 4 to 6 month infant child visit. The murmur is loudest over the pulmonic region and is associated with a fixed splitting of the S flow during different phases of respiration and a loud S. The murmur heard is from increased blood flow across the pulmonary valve because of the greater volume of blood in the right side of the heart relative to pulmonic stenosis. An additional diastolic murmur may be heard at the left lower sternal border from excess flow across the tricuspid valve. There may be left precordial bulging due to the enlarged RV being present during cartilaginous rib development. Patients with ASDs are usually asymptomatic but may have some fatigue. They are followed up with Doppler echocardiography to monitor enlargement of the right atrium and /or RV, which, if present, indicates hemodynamic significance. 9 infants with an ASD manifesting with features of CHF tachypnea, increased work of breathing, frequent pauses in feeding, failure to thrive, profuse sweating while feeding, decreased activity levels must be investigated for an additional lesion such as a PDA, VSD with pulmonary. Volume 38, No. 10 October 2017, 473. Downloaded from http://pets and review, publications, /by967986 on January 30, 2019. Arterial stenosis, or left-sided obstructive lesion core tritriatum, cortation, aortic or mitral stenosis. Management. Secundum AS can be repaired either surgically by using a patch or a primary suture closure of the defect or in the cardiac catheterization laboratory by using an ASD closure device. 10, 11 ASDs that are too large or do not have appropriate anatomy usually require surgical repair. 12, there has been no significant difference shown in studies comparing the procedures, and there is also no difference observed clinically. Typically, in clinical practice, patients with hemodynamically significant AS are referred for intervention around 3 to 4 years of age. Rarely do ASDs have to be closed earlier. Ventricular septal defects VSDs are the most common CHE lesion and are present in 50% to 60% of all children with CHD. 1, 2, 3, 4 VSDs develop from defective formation of the interventricular septum and are classified on the basis of their location in the septum relative to the atrioventricular valves and the right and left ventricular outflow tracts. Paramembranous VSDs deficiency in a fibrous part of the septum at the base of the heart are the most common type, constituting about 80% of all VSDs, followed by doubly committed juxta, arterial deficiency in the infundibular septum, between the pulmonary and aortic valves, muscular in the tracheal part of the septum, and inlet deficiency in the septum inferior to the paramembranous region and above the level of chordal attachments of the atrioventricular valves. Size of the VSD is defined relative to the area of the aortic valve, small less than 1/3 of the area, moderate 1/3 to 2/3 of the area, and large more than 2/3 of the area. Clinical manifestations and diagnosis. A newborn with a VSD may not initially have a murmur. However, as the pulmonary resistance decreases with age, an coincident pansystolic murmur can be heard the loudest over the left lower sternal border. Diastolic rumble at the apex may be heard from excess flow across the mitral valve. The child with a hemodynamically significant VSD presence with features of pulmonary overcirculation and CHF. Chest radiograph shows cardiomegaly with pulmonary vascular congestion Fig 2, while EKG shows left or biventricular hypertrophy. As the child grows, some paramembranous VSDs can get occluded by aneurysmal tissue, and muscular VSDs can become smaller in size with muscular growth. One must be wary of the paramembranous defect that becomes smaller owing to prolapse of the aortic valve. Management. Children with VSDs are regularly followed up by pediatric cardiologists. Children with CHF symptoms are temporized with diuretics, usually furosemide. Figure 2. Frontal chest radiograph in a patient with a ventricular septal defect shows features of congestive heart failure, including cardiomegaly and increased pulmonary vascular congestion, as well as splaying of the bronchi, which is indicative of left atrial enlargement. Sometimes chloral thiazide and / or spironolactone, and may require frequent evaluation of electrolyte levels. Patients with failure to thrive may need up to 125 to 150 kcal/kilogram per day of caloric intake through 4-5 formula. Close, reliable, and accurate monitoring of weight, with attention to using the same weighing scale and reinforcement of education about proper mixing of formula, are critical goals to be reviewed during the weight check visits at the pediatrician's office. With current surgical success in treating these lesions, there is little need for prolonged medical treatment. Surgical patch repair of the VSD is performed either in a symptomatic infant or in a toddler who has enlargement of the left atrium or ventricle at echocardiography. Sometimes paramembranous and doubly committed juxta, arterial VSDs can be associated with prolapse of the right or non-coronary cusp of the aortic valve through the defect, which may cause progressive aortic insufficiency. These VSDs are repaired even in asymptomatic patients. Some VSDs, for example, muscular VSDs, can be closed with devices in the cardiac catheterization laboratory. After VSD repair, these patients need to have continued follow-up of weight and nutrition to ensure regaining of growth curves. Atrioventricular septal defects, AVS, also known as atrioventricular canal defects, constitute 5% of CHD. 1, 2, 3, 4. About 50% of patients with AVS have Down syndrome. AVS arise from defects in the proliferation and fusion of the endocardial cushions and are classified on the basis of the commitment of the common atrioventricular valve to the ventricles, the presence or absence of separate orifices, and the anatomy of the subvalve. 474 Pediatrics and Review downloaded from http://Pets and Review, Publications, by 967986 on January 30, 2019. Attachments. Most commonly, patients have a primary type of ASD, as well as an inlet type VSD component, and in addition, they may have a lack of completed position or coaptation sole, called cleft in the mitral valve. Clinical manifestations and diagnosis. Patients with AVS typically have a systolic ejection or holosystolic murmur from the VSD component. However, if the VSD is large and there is equalization of pressures in the ventricles or if pulmonary hypertension is present, a murmur may not be heard. Additionally, these patients may have murmurs of atrioventricular valve regurgitation, characterized as a some coincident systolic murmur, heard the loudest over the apex in the case of left-sided regurgitation and the loudest over the right lower sternal border in the case of right-sided regurgitation. Diastolic rumble may be heard, similar to that heard in patients with VSDs. An EKG in these children shows left, right, or biventricular hypertrophy and may have a northwest axis, negative axis, and leads eye, Woman 2, Woman 3, and a VF, which is suggestive of a diagnosis of AVS Fig 3. These children may also present with features of CHF and failure to thrive, with chest radiographic findings as previously described in the VSD section. Severe atrioventricular valve regurgitation, creating more prolonged, will exacerbate earlier CHF symptoms. Management. Patients with AVS with an additional diagnosis of Down syndrome may remain in the hospital for a prolonged period of time as a neonate or in feeding difficulties. All patients with AVS are closely followed up, since they typically require surgical intervention around 4 to 6 months of age or earlier if they have severe CHF or failure to thrive. The diuretic and nutritional management and close monitoring for CHF is similar to that in patients with VSD. While the surgical mortality rate in the current surgical era is less than 3%, the need for reintervention owing to atrioventricular valve regurgitation or stenosis remains about 10% to 15% at the 5-year postoperative mark. 13-14. Patent ductus arteriosus. An arterial duct is a normal fetal connection between the aorta and the pulmonary artery that is present in all newborns. It closes functionally within 24 hours and anatomically within 3 to 4 weeks in most patients. It may remain patent longer in some patients, especially infants born prematurely. Clinical manifestations and diagnosis. The examination. A patient with PDA varies with their age. In a newborn with high pulmonary resistance and pressures, the PDA may not shed much blood and may not be audible. And in female 6-2 Monday Calves rate PR turbo QRS direct noti QT FX TS 147 M14 30% 470 55 262 7 asterisk pediatric ECG asterisk normal by the northwest pole spray attractive condition delay bubble ventricular bipertratry diatric analysis M1 compare TH ECG of continuous murmur of blood shedding left to right during the entire cardiac cycle, which is loudest over the left precordium. In an older patient with a hemodynamically significant PDA, one may be able to detect the diastolic rumble of transmitral flow into an enlarged left ventricle LV. Left, 2. Right shedding caused by the PDA may also lead to features of CHF. Chest radiographs illustrate features of pulmonary overcirculation and cardiac enlargement. EKG can show LV hypertrophy and segment changes of ischemia. Beware of this finding in a newborn, as it implies a very large shunt. And Doppler echocardiograms can demonstrate left atrium and LV enlargement, characteristics of flow, and anatomy of the PDA. Management. Ibuprofen and indomethacin have been used to medically close PDAs in premature PDA, and in very rare instances, an ASD that present late may have pulmonary hypertension. Pediatricians may encounter these scenarios when examining patients who have not had access to medical care, for example, patients from some developing countries or areas of the United States that are medically underserved. The degree of pulmonary hypertension due to pulmonary vascular obstructive disease may be prohibited for repair. Some of these patients will be treated with agents that lower pulmonary hypertension and may later in life go on to develop Eisenmenger syndrome when pulmonary vascular resistance exceeds systemic vascular resistance, resulting in a reversal of the shunt and its associated sequelae. Aortic and pulmonic valve stenosis. Aortic stenosis constitutes 5% to 8% of all CHD, and pulmonary stenosis constitutes about 8% to 10% of all CHD. 1, 2, 3, 4. The degree of stenosis is categorized as critical if the blood flow through the respective valve is insufficient and requires additional contribution from the PDA. These valves undergo aberrant tissue resorption during in utero development, which leads to thickened dysplastic valves that do not open or close normally. Hence, they create obstruction to blood flow and may also be regurgitated. Aortic stenosis may be associated with a bicuspid or even a unicuspid aortic valve, as well as other levels of obstruction in the left-sided circulation, including CoA, subaortic obstruction, and mitral stenosis. A bicuspid aortic valve has been found to be associated with aortic root dilation due to an aortopathy and requires close follow-up, even if there is no stenosis across it. Clinical manifestations and diagnosis. Patients present with an ejection systolic murmur that is loudest over the respective valve region and may also have an ejection click if stenosis is moderate or mild. The aortic click is heard at the apex and right upper sternal border and does not vary with respiration, whereas the pulmonary click heard at the left lower and upper sternal borders will be loudest when the patient exhales. EKG may show ventricular hypertrophy of the RV in cases of pulmonic stenosis and of the LV in cases of aortic stenosis. Doppler echocardiograms help estimate the velocity of blood flow across the valve. Based on the continuity equation, the narrower the valve area, the faster the flow velocity. This flow velocity is then used to estimate the pressure gradient across the stenotic valve by using a modified Bernoulli principal peak velocity in meters per second squared times 4. Management. Patients with critical aortic stenosis or pulmonic stenosis meet a class I indication to undergo a catheter based balloon valvuloplasty procedure in the newborn period to ameliorate ductal dependence. 918 for non-critical stenosis. The time of intervention is determined by the presence of peak gradient of 250 mmHg obtained across the aortic valve, 240 mmHg in the setting of ventricular dysfunction, or 40 mmHg across the pulmonary valve at echocardiography or during cardiac catheterization on the basis of the American Heart Association guidelines class I indication 919. Patients with aortic stenosis may undergo a surgical valvuloplasty, depending on the valve anatomy and less size and experience and preference of the personnel at the center. There has been no reported significant difference in survival or rate of aortic valve replacement between patients undergoing balloon valvuloplasty and those undergoing surgical valvuloplasty, although patients undergoing balloon valvuloplasty may have a greater frequency of reintervention. 102021 patients undergoing balloon valvuloplasty of the aortic valve in the first year after. 476 Pediatrics in review downloaded from http://pets and review applications / I967986 on January 3, 2019. Birth typically need reintervention in about 50% of the critical aortic stenosis cases and 33% of the non-critical aortic stenosis cases, necessitating long-term follow-up for restenosis and/or regurgitation. 1819 patients undergoing balloon valvuloplasty of the pulmonary valve may not require another procedure for several years or ever again. However, they do require regular cardiology re-evaluation and Doppler echocardiography to assess the need for reintervention due to restenosis and/or regurgitation. 9. COA and interruption of the aorta. COA is a narrowing at the isthmus of the arch of the aorta with concomitant narrowing of the transverse arch in some cases, constituting 3% to 8% of CHE. 1234 IA is the most extreme end of this spectrum, with the discontinuation of the arch and distal continuation through a PDA past the point of interruption. IA accounts for about 1.5% of CHE and is classified according to the site of the interruption. Type is interrupted at the isthmus distal to the left subclavian artery. Type B is interrupted between the origins of the left subclavian and left common carotid arteries, the most common type and frequently associated with chromosome 22 abnormalities. And type C is interrupted between the origins of the innominate and left common carotid arteries, the most rare type. About 80% of patients with IA have an associated VSD. Clinical manifestations and diagnosis. Severe and critical. COA and IA may be detected at the time of newborn screening with a lower saturation level at the post-rectal site or via clinical suspicion on the basis of poor pedal or femoral pulses at the first newborn visit to the pediatrician. These patients may present in extremis at 2 to 3 weeks of age, in shock, with feeble pulses, lethargy, poor feeding, decreased urine output, and metabolic acidosis. While sepsis remains the most common cause of this constellation of symptoms, an echocardiogram should be performed for COA and/or IA if the shock is unresponsive to fluid resuscitation. Mild COA may be detected on the basis of a gradient of more than 20 mmHg between the upper and lower extremity blood pressures carefully performed with proper technique during infancy. A harsh systolic murmur that is loudest over the back may be heard. COA may also be found in young adolescents undergoing workup for hypertension. There may not be a clinically significant blood pressure gradient in older patients with COA because they develop collateral vessels over time that supply blood distal to the narrowing. In the case of collateralization, one can detect a continuous murmur of the flow in these vessels over the chest wall. Management. Newborns with severe or critical COA and IA are dependent on prostaglandin infusion to keep the PDA open until the time of surgical repair. Some children, particularly older children, are candidates for intervention in the cardiac catheterization laboratory with balloon angioplasty and stent placement for the cortation videos 12. 22-23 after repair. Patients are followed up closely in the cardiology clinic to monitor for recurrence of COA and persistent hypertension and continue to receive long-term follow-up at 1-2 year intervals. Cyanotic CHD. Tetralogy of Fawlard. Tetralogy of Fawlard is the most common cyanotic CHD, accounting for 5% of all CHD. 1-2-3-4 it develops from anterior malalignment of the interventricular septum, which leads to a VSD, as well as overriding of the VSD by the aorta. There is a narrowing of the pulmonary outflow tract due to the septal deviation, and this causes RV outflow and fundibular obstruction and consequent RV hypertrophy. Videos 3-4. Clinical manifestations and diagnosis. Patients with tetralogy of Fawlard have a harsh ejection systolic murmur heard over the pulmonic area, indicating pulmonic stenosis. There may be a single second sign. Higher saturations indicate less RV outflow obstruction. Patients who do not receive a diagnosis prenatally may present for the first time as children having a hypercyanotic spell in a period of agitation, fever, or other concurrent illness. Agitation and crying increase pulmonary vascular resistance, while also increasing the heart rate owing to a subsequently shorter diastolic period. Ventricular filling is less, which adds to the obstruction to the RV outflow from its hypertrophic muscle bundles. Death spells may become a vicious cycle and require a video 1. Aortogram in a teenager with cortation of the aorta demonstrates narrowing of the descending aorta. Volume 38 No. 10 October 2017 477. Downloaded from http://pets and review applications /I967986 on January 30, 2019. Video 2. Aortogram obtained after angioplasty in a patient with cortation of the aorta who underwent stent placement in the cardiac catheterization laboratory. The narrowing is abolished with stent placement. Combination of heart rate control and vascular resistance. Manipulation to break. The murmur during a hypercyanotic spell or TET spell becomes softer because of decreased pulmonary flow. Iron deficiency anemia will accelerate the onset of these spells. Management. The time of presentation and intervention for tetralogy of Fawlard is determined by the degree of RV outflow obstruction and the limitation of pulmonary blood flow. 24 of these clinical indicators are the oxygen saturation levels and the development of hypercyanotic spells. The Doppler echocardiographic indicators are the pressure gradients observed across the RV outflow tract. Children with saturations less than 80% or those having hypercyanotic spells are scheduled for surgery. Acute test spells are managed by first helping to calm the patient, for example, handing the child to the parent to hold, allowing the child to feed, or administering sedation if needed, placing the child in the knees. 2. Chest position to increase systemic vascular resistance. This may be achieved by having the parent hold the baby in her arms and cradling the knees and chest together, initiating oxygen preferably through the least noxious route for the child, for example, blow, or oxygen or use of a face mask, administering a bolus of intravenous fluids, and finally, intravenous metoprolol to slow the heart rate and phenylephrine to increase systemic vascular resistance. Some patients will require anesthesia on the way to the operating room. Surgical management includes palliative procedures like a modified Blalock, Tulsi, Thomas MBTT. To help provide consistent pulmonary blood flow in the setting of significant stenosis or atresia of the pulmonary valve. Complete repair of the heart comprises closure of the VSD, as well as resection of the RV obstruction, resulting in FR95 HE 5.0 centimeters, 2093% C46P off general 0. Video 3. Echocardiogram in a patient with tetralogy of Fawlard. 4. Chamber view of the heart is shown, with the left side of the patient on the reader's right. The ventricular septal defect VSD and the right ventricle RV hypertrophy are demonstrated. The aorta rises from the left ventricle and overrides the VSD. As the video plays, it sweeps through the heart anteriorly to show the pulmonary artery, which appears narrow. The hypertrophic muscle bundles of the RV are also seen, especially in the subvalvular region, which come very close together in systole. This creates a setup for dynamic obstruction to blood flow out of the RV. 478 Pediatrics in review downloaded from http://pets and review applications /I967986 on January 30, 2019. Normal saturations. Complete repair is replacing the palliative approach in many centers. Even after complete tetralogy of Fawlard repair, patients require lifelong cardiology follow-up, since their pulmonary valve may become more regurgitant depending on the surgical approach and the intervention on the valve annulus itself, which can lead to RV dilation. Patients may also develop arrhythmias because of the RV dilation and/or hypertrophy and scarring as a result of the pulmonary valve regurgitation, as well as the primary surgery, with an increase in risk of sudden cardiac death in pediatric patients with QRS duration longer than 170 ms on the EKG. 25, 26 cardiac magnetic resonance imaging is used to estimate the volume of the RV to determine the time for pulmonary valve replacement catheter, based or surgical. While complete repair of tetralogy of fallout ensures that these children have normal saturations, most patients have a prolonged QRS duration and features of right bundle block on the EKG, owing to the intervention on the interventricular septum. Transposition of the great arteries. Transposition of the great arteries is the second most common cyanotic CHD, accounting for about 2% of all CHD. 1, 2, 3, 4. It is the most common cyanotic heart disease manifesting in the first week after birth. There is ventricular arterial discordance, with the aorta rising from the RV usually anterior to the pulmonary artery and the pulmonary artery arising from the LV. Hence, the systemic and pulmonary circulations are in parallel, with systemic venous deoxygenated blood returning to the right atrium, the RV, and going out the aorta again. There is mixing of blood at the atrial level through a pen foramen ovale or an ASD, or at the ventricular level through a VSD. 35% to 40% of transposition of the great arteries. Clinical manifestations and diagnosis. Newborns with transposition of the great arteries present with cyanosis within the first 12 hours after birth and are not responsive to oxygen or mechanical ventilation. The presence of a VSD may delay presentation. Chest radiography may show a narrow mediastinal silhouette due to the orientation of the great vessels and thymic regression, and EKG results may be normal or show RV hypertrophy. There is usually no MUR at examination. However, there may be a single S with a loud aortic component due to the orientation of the great vessels. Management. Once the diagnosis is established, these patients require reparative surgery to switch the great vessels to the appropriate ventricles, known as the arterial switch procedure. 27. They may need respiratory support with oxygen, mechanical ventilation, and initiation of prostaglandin, until the time of surgery. Prostaglandin allows the PDA to remain open, which sheds blood from the aorta into the pulmonary circulation. This increases the amount of blood returning to the left atrium and mixing at the atrial level, as long as the foramen is open. Most patients undergo a catheter-based procedure called balloon atrial septostomy to help create or enlarge the ASD to allow more mixing while awaiting surgery. If cyanosis persists despite an open PDA, a fluid bolus or nitropic support may help improve mixing and systemic arterial saturations. After repair, these patients require regular cardiology follow-up for life. The first arterial switch procedure was performed in 1975, and since the patients undergoing this procedure are followed up for progressively longer periods of time, data about the long-term complications are emerging. Depending on the study, 5% to 30% of these patients have been reported to require reintervention at 25-year follow-up for a variety of reasons, most commonly regurgitation of the new aortic valve more than 75%, supravalve or pulmonary stenosis more than 75%, and coronary artery disease 5% to 8%. 28-29, truncus arteriosus. Common arterial truncus arteriosus accounts for 2% to 5% of CHE and manifests early in the neonatal period. 1, 2, 3, 4. It develops from lack of formation of the aortic pulmonary septum. Hence, the common truncal outflow does not divide into an aorta and a main pulmonary artery. There is always an associated VSD, and there is a common truncal valve, most commonly either tricuspid or quadricuspid. About 1/3 of the patients with truncus arteriosus have a 22-11. 2. Lesion di-George or velocardiofacial syndrome. Clinical manifestations and diagnosis. Patients with truncus arteriosus present within the first 48 hours after birth with symptoms of profound pulmonary overcirculation. On examination, they have a systolic murmur heard the loudest over the left sternal border, as well as a loud S-swell. Multiple sounds may be heard that temporarily coincide with the timing of the song. A general physical examination may also demonstrate features of 22-11. 2. Deletion, including a small mouth micronathia, cleft lip and slash or palate, and flat cheekbones malaflattening. 30. Management. Symptoms of pulmonary overcirculation may be managed with diuresis and fluid restriction. These children undergo surgical repair in the first 2 weeks after birth. 31. The truncal outflow and the truncal valve are committed to the aorta, and the branch pulmonary arteries are committed to a conduit placed from the RV to the pulmonary artery. These children should have normal saturations after repair. They continue to require close cardiology. Volume 38 No. 10 October 2017, 479. Downloaded from http://Petson Publications, /I967986 on January 30, 2019. Follow up over the years as they outgrow their RV. Top pulmonary artery conduit only 50% are free of RV. Top pulmonary artery conduit reintervention at 10 years. And their truncal valve, now their committed neo-aortic valve, may become regurgitant. Only about 23% are free of reintervention for the truncal valve at 10 years. 31. Other than their cardiac concerns, they should also undergo 22-11. 2. Deletion testing by way of chromosomal microarray analysis and a genetics consultation, regardless of whether the typical faces are present. 30. Serum electrolyte testing for calcium levels should also be performed in all cases, while awaiting chromosomal microarray analysis results to rule out hypocalcemia that may be seen in patients with 22-11. 2. Deletion, total and partial anomalous pulmonary venous drainage, abnormal return of the pulmonary veins to the systemic veins or the right atrium comprises about 1% of CHD. 1, 2, 3, 4. Anomalous pulmonary venous return is defined as a partial anomalous pulmonary venous drainage path when at least a pulmonary vein returns to the left atrium, and Roman 2. Total anomalous pulmonary venous drainage path when none of the pulmonary veins return to the left atrium. Path can be further classified on the basis of the site of return of the anomalous drainage to the systemic veins, supracardiac into the superior vena cava system, intracardiac into the coronary sinus or right atrium, or infracardiac into the inferior vena cava IVC or hepatic venous system. Blood returning from the pulmonary veins to the right side of the heart causes right atrial hypertension, with right 2. Left shedding across a pan foramen ovale and slash or an ASD. TAV. All the venous return to the heart returns to and mixes in the right atrium before shedding across the interatrial septum or coursing across the tricuspid valve. Hence, the saturations in each of the cardiac chambers are the same. Clinical manifestations and diagnosis. The number of veins returning anomalously and the degree of obstruction determine the rate and severity of the manifestation. Physiologically, TAV can be categorized as I obstructed, in which case the pulmonary venous return is impeded, which can lead to pulmonary venous hypertension and pulmonary edema, or Roman 2 unobstructed, in which case the anomalous drainage causes cyanosis due to mixing after return to the right side of the heart, but does not cause respiratory distress in the first days after birth. The newborn with obstructed TAV presents with respiratory distress and cyanosis within 12 to 24 hours after birth, with a classic chest radiographic finding of a whiteout of the lung fields. Due to backing up of blood flow prior to the site of the obstruction of pulmonary vein drainage and be a small heart on chest radiographs, the respiratory distress does not respond to oxygen and may potentially be worsened by starting prostaglandin as more blood starts shedding to the pulmonary circulation at the ductal level, to the point of pulmonary edema or lung bleeding. TAV, which may or may not be associated with an ASD, typically manifests later in life in childhood or adolescence with signs similar to those of an ASD, with an ejection systolic murmur that is loudest over the pulmonic region owing to the increased blood returning to the right side of the heart. EKG shows right atrium and RV enlargement, and Doppler echocardiographic findings confirm them. Diagnosis, management. Obstructed TAV constitutes about 1/3 of the cases and is a surgical emergency. 30-31 children with an obstructed TAV can be followed up by a cardiologist for a brief time as outpatients with a definite plan for early surgical repair, since obstruction can develop over time and manifest similarly with respiratory distress. After repair of TAV, patients continue to be closely monitored as outpatients, since pulmonary venous obstruction can recur, with reported rates around 15%. 32-33 evaluation of the anastomosis site at echocardiography is especially important. Recurrent pulmonary venous obstruction manifests as respiratory distress, tachypnea, and wheezing that is not responsive to bronchodilation. These patients require chest radiography and echocardiographic evaluation if they have not undergone a recent study to assess their pulmonary venous drainage. Stable patients with PAP are scheduled for elective surgical repair if indicated and are followed up as an outpatient in the cardiology clinic every 1 to 2 years. HLHS, tricuspid atresia, and single ventricle palliation. HLHS is the 4th most common form of cyanotic CHD, comprising severe stenosis or atresia of the mitral and aortic valves. 1, 2, 3, 4 owing to decreased flow from the left atrium into the LV, as well as from the LV into the aorta. The LV is hypoplastic, and there is associated hypoplasia of the ascending aorta, as well. Video 5. This lesion is PDA dependent for systemic circulation, as the descending aorta continues from the PDA insertion, and the coronary arteries, denominate arteries, left common. Carotid arteries and left subclavian arteries are supplied primarily by retrograde flow from the PDA. Prostaglandin infusion is required to maintain PDA patency. Corresponding lesion on the right side of the heart is a hypoplastic RV in the setting of severe tricuspid stenosis or atresia in severe. 480 Pediatrics and review downloaded from http://pets and review, applications, / I96. Ventricles, the absence of a normal or repairable atrioventricular connection in the form of severe stenosis or atresia of the mitral or tricuspid valves, the absence of a repairable outflow. In fact, in some situations, severe stenosis or atresia of the pulmonary or aortic valve, or any combination of these conditions indicates that patients should undergo single ventricle palliation. 34 of these lesions are dependent on FR95 HE8.0 into both systemic and pulmonary circulations. The subtypes of these lesions have variable physiology and are beyond the scope of this article. We will proceed to discussing the stages of palliation by using HLHS as a model. The first stage is to help stabilize both cardiac outputs, either by surgically constructing any aorta by using the main pulmonary artery tissue to supplement the ascending aorta, the Norwood procedure, creating an MBTT shunt or RV. 2. Pulmonary artery conduit to supply blood flow to the pulmonary arteries, and creating an AST. This first stage may also be performed in a hybrid fashion in the cardiac catheterization laboratory and / or operating room. The details are beyond the scope of this article. The second stage, known as the Glenn procedure, involves anastomosing the superior vena cava to the pulmonary arterial system to direct part of the deoxygenated venous blood directly to the lungs. This also allows take down of the MBTT shunt or RV. 2. Pulmonary artery conduit, as there is consistent pulmonary blood flow through the Glenn connection. The final step of this palliation deforming procedure is to connect the IVC to the pulmonary arterial system as well, to allow all the deoxygenated blood to go straight to the lungs without mixing in the heart. First fig 4. The phonic connection may be fenestrated in some cases, creating a connection between the IVC, pulmonary arterial anastomosis, and the pulmonary venous atrium. This may be especially useful as a pop-off for blood passively returning from the IVC to the pulmonary circulation in cases of high pulmonary vascular resistance. Clinical manifestations and diagnosis. The presentation of single ventricle lesions depends on the adequacy of cardiac output. Systemic cardiac output is dependent on the ductal blood flow. In patients with HLHS, when the duct starts to close, the infant begins to have signs of poor systemic perfusion with feeble pulses, poor urine output, shock, and modeling, in addition to pulmonary overcirculation, seen as tachypnea and respiratory distress. Chest radiographs will show pulmonary vascular congestion, in addition to possible cardiomegaly due to right ventricle only as a result of the RV effectively handling systemic as well as pulmonary cardiac output. Management. The first stage surgical intervention is performed within the first 2 weeks after birth. Saturations after the first stage palliation can vary from 80% up to 95%, depending on the amount of pulmonary blood flow. Continuous or pansystolic murmur is easy to appreciate in a child with an MPTT shunt and a systolic ejection. 321 Bra. Lab RV. 2014 Texas Children's Hospital. Figure 4. Diagram shows the shunts and sites of anastomosis for single ventricle palliation by using hypoplastic left heart syndrome as a model. That indicates the reconstructed new aorta by using the hypoplastic ascending aorta, as well as the normal main pulmonary artery, to ensure stable systemic outflow. It indicates the site of the modified Blalock-Taussig. Time is shunt to direct blood flow from the right subclavian artery into the pulmonary circulation. This is taken down at the time of the second stage of palliation, the Glenn anastomosis. This involves the creation of an anastomosis between the superior vena cava and the right pulmonary artery. 2. The final step in this palliation is the phonic anastomosis. 3. This disconnects the remaining deoxygenated blood coming in through the inferior vena cava and redirects it through the phonic conduit to the pulmonary circulation. This final step eliminates any mixing and completely separates the oxygenated and deoxygenated blood, ensuring normal saturations. LA equals left atrium, LV left ventricle, RA equals right atrium, RV equals right ventricle. Printed with permission from Texas Children's Hospital. Murmur is heard with an RV. 2. Pulmonary artery conduit. As these children grow older and bigger, the relative size of their MPTT shunt or RV. 2. Pulmonary artery conduit limits the amount of pulmonary blood flow for their body surface area, and their subacute bacterial endocarditis prophylaxis, and postoperative and cardiac catheterization care. All patients undergoing cardiopulmonary bypass should not receive live vaccines for 2 weeks before or 6 weeks after cardiopulmonary bypass. Cytokine and immunologic markers return to normal by 2 months after surgery, and the vaccination schedule can be resumed. 35-36 Most children should receive the influenza vaccine. Children younger than 12 months with unrepaired cyanotic CHG or those receiving diuretic therapy for CHF and canonic CHG should receive respiratory syncytial viral prophylaxis with palivizumab. 37 Further, for children who meet the criteria for respiratory syncytial viral prophylaxis after a palliative surgery involving cardiopulmonary bypass, a postoperative dose of 15 mg/kg palivizumab should be considered. Children undergoing cardiac surgery or interventional catheterization procedures to repair a lesion or occlude a defect requires subacute bacterial endocarditis SB prophylaxis for 6 months after the procedure and indefinitely if residual defects are present around a patch and/or a device. All children with unrepaired cyanotic CHG require SB prophylaxis. Children who have prosthetic or bioprosthetic valves or conduits implanted percutaneously or surgically should receive lifelong SB prophylaxis. Children with a prior history of endocarditis or who have valvular heart disease in the context of heart transplantation also require SB prophylaxis. 38. After cardiac surgery via median thoracotomy, patients observe sternal precautions for 6 to 8 weeks. 39-40 The precautions vary from center to center, but the general principles include no prone position or tummy time unless they can roll and be prone voluntarily. Roman 2 close supervision when playing with other children and avoiding crowded places. And Roman 3 avoiding picking up or lifting the patient by the arms or armpits and instead trying to scoop up the patient. The patient can continue to be in an age and weight appropriate car seat after cardiac surgery, after the period of sternal restriction. Summary 1. On the basis of clinical consensus and research observation, newborns with ductal dependent congenital heart disease CHD may present with cyanosis or shock as the peden ductus arteriosus starts to close, indicating the need for prostaglandin to maintain output to the pulmonary or systemic circulation. 5782. On the basis of research evidence, as well as clinical consensus, children with canonic shunting lesions can present with features of congestive heart failure and require nutritional and diuretic optimization until the time of early surgical correction. 1293. On the basis of research evidence, as well as clinical consensus, children with cyanotic heart disease may undergo early corrective surgery or, in some instances, undergo palliation with a shunt modified Blalock-Taussig. Time is shunt to supply pulmonary blood flow prior to their corrective surgery. 2232. 4. On the basis of strong clinical evidence, children who undergo single ventricle palliation are at risk for developing complications at any stage of the palliation. 31. To view teaching slides that accompany this article, visit the basis of clinical evidence, as well as clinical consensus. Although most children with corrected CHG have a normal quality of life, lifelong cardiology follow-up is needed for all of these patients to monitor the development of any long-term complications and/or sequelae. 1314.